Good morning. My name is Maria Walls. I'm an internal medicine nurse practitioner. You are joining me on a weekend, so don't be surprised if there's some background music. I have children, one who's watching a show, a movie, and I have two dogs. So as far as my background, I have been a nurse practitioner for 14 years in internal medicine. I started in internal medicine and rheumatology. Before that, I worked for 6 years as a registered nurse at a level 1 trauma center, lots of PRN jobs, home health. I did nursing home. I did multiple others as well. I've also worked in healthcare actually since the age of 18 as a unit secretary, as a patient care tech, as a graduate nurse. And so I've been working in healthcare since for a very long time. It was my ER experience that really drew me to work more with COVID-19 in the last 2 years. So I did work in our virtual care center doing virtual visits when the pandemic first started with patients to determine whether or not they could be stay-at-home self-care measures, or if they needed to go to the emergency department, or they needed in-person evaluation. And then also our respiratory clinic, which is where we send our medical groups, sick patients, if they need to be examined, imaging, blood tests, EKG, things like that, but they don't necessarily need the emergency room, or we're not quite sure. So that's kind of my experience. Of course, I have my own patient panel, and I've had hundreds and hundreds of patients with COVID, both mild and severe. So let's start. We're just going to kind of review all of this and start all over, just so that kind of everybody can get educated on COVID-19 again. Let's talk about the virology of coronavirus. So coronaviruses are what's called enveloped positive stranded RNA viruses. So it's one of the types of viruses that we have. Full genetic sequencing shows that COVID-19 is a type of what's called a beta coronavirus, which is most similar to SARS and MERS. SARS first emerged in 2003 in China, and it really affected between the ages of 25 and up. And what really scared us about this is that there was a 3% case fatality rate with SARS. And we knew that with international travel, this could end up being terrible, an epidemic, an endemic, but potentially a pandemic. Thankfully, it did not. It did. Then we have MERS, which that's emerged in the Middle East in 2012 initially, and then again in 2015. Again, went back to travelers. So people are infected by people who were traveling. And now we have so much international travel that this is why this is so scary. Luckily, these did not go global, and we were able to get them under control, but it was a very scary moment for those working in immunology and infectious disease. The closest RNA virus is to two bat coronaviruses. So this is where the bat coronavirus theory comes from. This is the most likely source. Whether it's transmitted directly from bats or through an intermediate host, so someone else that spreads it to a human, is unknown. So we're still doing a lot of research on this and a lot of investigating of where the source is. SARS-CoV-2 enters the cell through the ACE2 receptor by binding to the spike protein. Probably everyone has heard about the spike protein, and you can see the picture up here at the top right corner that kind of shows you the structure of SARS-CoV-2 and what the spike protein looks like. The spike protein is actually very, very difficult to see, and the person who discovered and actually saw it for the first time had to use amazing technology, which is a really cool story if you ever want to look at it. So how does it infect you? So we usually are infected with COVID-19 through mucous membranes. So usually through the nose or the mouth. And then you can see, I'm going to start here up the top. I won't go through all this because there's a lot of detail on this slide. But at the top, it shows very healthy alveoli. So in your lungs, you have all these alveoli, and there's sacs. These are the sacs that fill up and then empty with air every time that we breathe. And you can see healthy alveoli are supposed to be nice and empty, and they open up all wide, and then they close all the way, and they open and they close. When people are infected, you can see that the SARS-CoV-2 viruses get inside those alveoli. And then when they have moderate to severe infection, it creates fluid-filled sacs. So you can see moderate here and then the severe at the bottom. What happens then is the alveoli cannot inflate or deflate, and then there's impaired oxygen diffusion. And this is where we're getting the really terrible pneumonias that are kind of all over the lungs versus a bacterial pneumonia we're used to seeing is many times in just one little part of the lung. Variants of concern and how they differ. So I'm going to go over the latest 3 variants and how they're different. Alpha was first identified in the UK in 2020, and more than a dozen mutations more than a dozen mutations compared to the previous ones. So this was the first one that we really started seeing many mutations, which made us nervous. It was associated with higher disease severity than the original variant. So this is when we were really seeing more deaths from COVID. Then we have Delta, which was first identified in India in 2020. We watched what happened in India. It's more transmissible than Alpha. That was the key thing. We knew that more people could spread it. With Alpha and the previous variant, sometimes you'd get one person in a household that had it, and not everybody would get it. But with Delta, it seemed like once one person in that house got it, most family members did. So that does have a higher disease severity as Alpha, and then the vaccines may not as be protective. So then we started seeing this drop in antibody levels from those that were vaccinated, and that the vaccines maybe weren't as protective unless it was just people were just recently vaccinated. But the vaccine still did seem to prevent hospitalization and death from Delta. Then we have Omicron, which is our newest variant to the team. It's first reported from Botswana, then South Africa. And then as of December 2021, it was the most dominant variant in the US. What's really crazy about it is it contains 30 mutations. It has much higher transmissibility, which means one person can infect many more people. And we have decreased susceptibility to monoclonal antibody treatments. So the one that we use most, which is called Regeneron, which we had a lot of, especially in my state, doesn't work for Omicron. So now we had to change the monoclonal antibody treatment that we're giving. Unfortunately, it also evades vaccines more. It may be milder in disease severity, which is what we were hoping, but unfortunately, we're not really seeing that here in my area. We'll talk more about the vaccine evasion here in just a few minutes. So those infected with prior variants are likely susceptible to this variant. So we actually have had several patients who had what we suspect was probably Delta because they were infected in October, November, get reinfected with the Omicron variant. Most people, their reinfection tends to be milder, but not always, especially in people who have comorbid conditions. And people that were relying on their natural immunity, we're finding people with that are not vaccinated that are relying on natural immunity are getting 6, 2, 3, 4 times now. And some tests may not be able to pick up, like the test that you buy at the store, the home test might not be able to pick up the new variant. You may get a false negative. That's why if you have symptoms of COVID, you need to stay home and take the same precautions. The PCRs do definitely pick up the Omicron variant. So transmission. So transmission is greatest early in the disease where the viral load is the highest. So the first few days of symptoms is usually when it's more likely for that person to give it to someone else. It depends on the type of exposure, the mitigation measures in place, and individual factors. What's very interesting is that we have found some people actually cannot get SARS-CoV-2 and cannot transmit it to other people. And there's theories behind this, and there's a lot of researchers working on this of why. And we think that it might be because of the number of coronaviruses that this person may have been exposed to in the past. There's various factors, but there are a very small amount of people that can't ever get it. Transmission is most likely in indoor spaces for prolonged periods. So that's why, of course, going into the fall and winter, we all get nervous in healthcare because we know people are getting together, they're inside, they're at close quarters, not masked, and things like that. Household is going to be the number one place where people get infected. Healthcare settings without proper PPE. So we know that people that are usually at the hospital and need to be admitted, they need oxygen needs, so they're going to have a higher viral load. And if our healthcare workers do not have proper PPE, these patients are in these rooms for long periods of time, so they have a lot of probably the virus in the air. And then congregate settings is the third most likely place where it's transmitted, like jails and homeless shelters and nursing homes and things like that, where you have a lot of people in a small area. Other high-risk settings are social gatherings, especially social gatherings with a lot of people with shared food. Restaurants, unless a restaurant has installed a really good ventilation system with filtering, there is a very high risk for transmission in restaurants. Drinking establishments, of course, that's why a lot of places in the country have shut down bars early and closed bars altogether when their numbers were really high. And then super spreader events in indoor spaces. So when you have a lot of people in an enclosed area and especially if it's not a big space. Also, traveling with someone who's infected with COVID-19 and also high risk, either in a car or a plane. And, planes tended to be pretty safe. If you were masked, in a plane, they actually filter the air. But I cannot tell you how many patients I connected with over the last couple of weeks who were known positive, who were out of town, who came back to where they live, positive, infectious, and admitted not keeping masks on me or coughing or sneezing while on that plane. Transmission by asymptomatic or pre-symptomatic individuals. So asymptomatic is obvious, they don't have symptoms, but pre-symptomatic is the first 2 days before people have symptoms. That can occur. It is possible, especially with household contacts, but it's not at the same rate as those that are symptomatic. That's why we're always saying if you have symptoms, please stay home. Transmission from surfaces is less likely, but it is possible. So the biggest risk, though, is, if you have someone who's unmasked, they sneeze, they cough, and they touch a surface, someone comes behind them, touches that surface, and then they touch their nose, their mouth, and their eyes. That's why we tell people, don't touch your face. Wash your hands frequently. Make sure you use the hand sanitizer. Hand sanitizer that's over 60% alcohol will kill the virus within 15 seconds. People that wear contact lenses instead of glasses, the reason why we have higher risk of transmission is because people who wear contact lenses tend to touch their eyes more. So when it comes to immunity, let's talk about natural or humoral immunity. This occurs when someone's already been infected by SARS-CoV-2. A majority of patients develop neutralizing antibodies after infection. So most people, when they get sick, they have antibodies for some time afterwards, especially if they're severely ill. So if they're hospitalized, if they're critically ill, they tend to surmount more of an antibody response. They have a higher level of antibodies afterwards. But those with mild illness may not develop antibodies at all. And we've seen this in our patient population where people get COVID. I had a husband and a wife, and husband was very critically ill. He had very high antibody levels. She was pretty sick. At home, she had none right afterwards. So there's some people that do not get that antibody response and have no protection after it. Most people's humoral immunity declines over several months, so we say probably about 90 days, but there have been a few studies that have shown some of them don't decline for 12 months or more. So we're still trying to figure out how do people build such a robust immunity to their infection and hold on to it for that long. Several studies have shown evidence of T-cell immunity. So this is something that we can't test for, in our local lab. And those that are previously infected or vaccinated, suggesting that we may have more long-term immunity. But the more mutations we have and the more variants we have, this may not be so protective. Reinfection in the first few months after infection is low, although it may be more likely with Omicron variant. So we're seeing this right now where people were infected just October and November and they're getting infected again. It is very rare in those infected and vaccinated. So in those of us when patients request an IgG spike level, we don't understand what level incurs immunity from the virus. But my patients who have been vaccinated, then they get natural immunity, have these huge IgG levels. So again, we don't know how long they stay around. We don't know how long they drop. Let's talk about prevention. So diligent hand washing or using alcohol-based sanitizer with at least 60% alcohol. Like I mentioned, with the alcohol sanitizer, it kills the virus within 15 seconds. And some autopsy reports have shown that the coronavirus or the COVID-19 virus actually stays on skin for a very, very long time. So it's very important to hand wash often. Respiratory hygiene is going to be coughing and sneezing in your elbow. If you have a mask on, don't remove your mask to cough or sneeze. Keep the mask on. That's the whole point of it. Not touching the face, because this is where our mucous membranes are and the most likely place for you to get infected. And adequate ventilation. We need more of this. This isn't really talked about a whole lot, but there's a lot of research studies that show opening windows when possible, placing a fan in front of a window, pushing the air out, keeping furnaces and ACs running at all times, and HEPA filters. The ventilation really makes a big difference. Social distancing, so maintaining 6 feet. So we know, when someone coughs or sneezes, we know that usually it doesn't go more than 6 feet, and avoiding ill individuals. Now, what's really crazy and probably has affected the transmissibility of the Omicron variant is that it may not just be carried in droplets, so it may be airborne at this point, and so that's why it's evading some of our mitigation measures. Disinfecting surfaces frequently. So those of us that work at a healthcare office, we're disinfecting our surfaces every hour on the hour, every time somebody gets up from a seat and things like that. And then wearing masks in public spaces, which we'll talk about masks in here in just a second. Other countries have implemented, so there are studies that show that other countries that have done the stricter measures have had a significant reduction in cases and deaths, which, as for example, social physical distancing orders, stay-at-home orders, school business closures, bans on public gatherings, travel restrictions, aggressive case identification and isolation. So as soon as you know that there's a positive, you're going to contact all those people they were in contact with and isolate all those people, and then contact tracing and quarantine of those people. Here is the relative size of particles. I've used this slide multiple times because it's really interesting, because a lot of people who are anti-mask, anti-vaccine use this. The coronavirus is so small, it evades all of our masks and masks are useless. They're right that the coronavirus is very small. So it's the third one from the bottom here, and it's only 0.1 to 0.5 microns. So it's very, very small. But like I said, most of the time, coronavirus does not travel alone. It travels in droplets. So when we sneeze or we cough or we talk, and you can see a drop is 5 to 10 microns. So most good masks will protect against this. So a surgical mask, an N95 and a KN95 definitely, or a fabric mask with multiple layers. So we know that probably our single fabric masks aren't very protective. Our gaiter masks aren't very protective. All right, sorry, I think you had some dogs barking there for a second. Okay. So vaccination remains the most promising approach to curb this pandemic. Let's talk about the vaccines. So we have 3 different trials for, this is going to talk really about people who say that the vaccine was rushed. So we have 3 phases that vaccine research goes through. Phase 1 is where we're really just assessing the safety and what dose to use. And then they do look at some immune response, but really they're just looking at safety. Phase 2 trials expand safety, and then they start to assess the immune response in a larger population. Is it effective, is what we're looking at. And then phase 3 is all about efficacy, and you have a control group to compare. So we're going to give this person the vaccine. It's all blinded. This person potentially won't get the vaccine, and how likely is this person with the vaccine able to get it versus this person that did not. These phases occur sequentially, and before going from one phase to another, it has to be approved. And then it usually takes years for each of these phases. There's a lot of documentation. There's a lot of paperwork involved. Due to the pandemic, because we needed some protection as quick as possible, they did each of the phases over months, but they still had to be approved before moving phase to phase, and all safety and monitoring was followed. For those of us who have worked in clinical medical research before, I used to be involved in rheumatology studies, there's a lot of monitoring, and if you do something wrong, your site is canceled. And so you cannot be doing all this deceiving things that people think that they're doing and lying and all of that kind of stuff. That's illegal. We sign all of these contracts with institutional review boards and things like that. And if we do something, potentially we can be held liable, and many of us, our careers taken away from us. So mRNA vaccines is a newer technology, but the research has actually been going on for a very long time. So they've used mRNA vaccines. They created this technology for MERS and SARS. Luckily, we did not need them because it did not go worldwide. The Pfizer vaccine is indicated for ages 5 and up, and Moderna for 18 and up. What they do is they take messenger RNA. Messenger RNA is a messenger. It's what it does is it comes in the body and it gives the message to the body that it's being exposed to SARS-CoV-2. Then that instructs the cells to make the spike protein to COVID-19, which then surmounts an immune response. So then you develop antibodies against COVID-19, so that if you were actually exposed to it, you already had the antibodies there to fight it off. And so if you did get it, it would be much milder. That messenger RNA never enters a cell. It would need 2 other catalysts to go into the nucleus of a cell. So it has no ability to change anyone's DNA, and it is gone within 72 hours out of that body. So it is decomposed by the body. There's a small risk for myocarditis, especially in our younger males. Myocarditis sounds very scary. It's inflammation of the heart muscle. It presents with chest pain, and it's very easily treated with NSAIDs, which is like ibuprofen or Aleve or a steroid pack. We see myocarditis quite often in medicine, and it is very easily treated. And the risk of it is very, very low. We have the Johnson & Johnson vaccines. So some people are very scared about this mRNA technology, and they prefer the Johnson & Johnson instead. Johnson & Johnson actually uses an inactivated cold virus to carry genetic material that creates a harmless piece of spike protein found on the surface of COVID-19, which then that's what surmounts an immune response. With the Johnson & Johnson vaccines, though, we do find that there's a small risk of thrombosis, which is blood clotting, thrombocytopenia, which is low platelets, and Guillain-Barré, because the Johnson & Johnson vaccine is very similar to the flu virus vaccine, which is where we see most of the Guillain-Barré cases. When it comes to efficacy with the initial trials, the mRNA vaccines were over 94% effective from keeping people from getting COVID and almost 100% effective on keeping people out of the hospital or having critical illness. When the Johnson & Johnson vaccine was around 70-something% effective. All vaccines lose effectiveness over time. And so we did see around 5 or 6 months, especially with the mutations, that our mRNA vaccines lost a lot of effectiveness. So we went from the 90s to the 70s. But once we had people get the booster shot, we went back over 90%. We never said that vaccines will guarantee that you will absolutely not get COVID-19. It is not a cure, but it is made to help prevent you from getting critical illness, from dying from it, and from having a very high viral load, which could potentially cause long haulers, which is something else you definitely do not want. The Johnson & Johnson vaccine is recommended. The effectiveness, if you're over 5 to 6 months on the Johnson & Johnson vaccine, you probably have no effectiveness for that vaccine any longer, and booster is recommended. mRNA vaccines are more effective, but I'll get production of the already said that. Okay, so post-exposure management. Let's say you're exposed to someone with COVID. What is the latest guidelines? The CDC suggests that all individuals without a history of infection in the prior 90 days who have had a close contact with a person in the community, including during 48 hours prior to that patient having symptoms, have some kind of isolation. So we do recommend testing 5 days following exposure to identify new infections promptly. We're preferring home testing, now because our volume is so high in our hospital systems, we usually are not testing asymptomatic individuals. So that's where the home tests come in play. Self-monitor, so look for fever, cough, upper respiratory symptoms, or other symptoms consistent with COVID-19. We're seeing a lot of GI stuff now, diarrhea and vomiting. So any kind of symptoms maybe suggest, especially after exposure, maybe think that you might need to be tested. If you do develop symptoms, make sure you stay home and maintain distance from other individuals, including your household. Like I mentioned, the household is the most likely place to transmit the virus, and then get tested for COVID after that 5-day period. Anyone who tests positive likely does have infection and should self-isolate. We do have a lot of false negatives, especially when people are testing too early or are vaccinated individuals, because when we get COVID, we don't hold such a high viral load. It may take a long time to show up, not a long time, but 3 or 4 days into a PCR as a positive. So if you feel like you could have COVID, we want you to self-isolate until we know. Unvaccinated individuals should self-quarantine for 5 days, so stay away from other people for 5 days. Mask around household members, so you can try to help protect your household members, especially if you have someone who's immunocompromised or older age or children that can't get vaccinated. And avoid contact with high-risk individuals, and then mask around others for 5 days. Vaccinated individuals should mask at all times for 10 days around others and monitor for symptoms. We're not saying that we want you to mask and go to work sick. If you're sick, you don't need to be at work. So assessment, this was more for my nurses because I did this lecture for nurses, but there are, for those of you thinking that you may have COVID, there's many patient self-assessment tools online. So you could Google COVID self-assessment tool, and you can fill out some questionnaires to make a decision of whether or not your symptoms could be COVID related. Telephone triage is appropriate for self-care at home. This is what we're doing with our nurse teams and our offices. We determine who can stay at home, who needs a video evaluation, who needs monoclonal antibody infusions or antivirals, and then who needs in-person evaluation, so urgent care respiratory clinics and ERs. Please do not go to the ER just to get COVID tested, or if you have mild symptoms, please use some of these other outlets, because our ERs are overwhelmed with not only COVID, but all of the other winter things that we see, and we really need to help keep people out of the ER for things like that. Assess for need to test. So of course we need to test symptomatic individuals, and the biggest thing is, people are like, I don't need to test, I don't have COVID. Well, the reason why I need to know is because I need to make sure that you stay away from other people, because maybe you're fine. If you're going to stay at your house the whole time, great. But you can't go to work, and be working next to your coworker who may have hypertension and morbid obesity and diabetes, who might not fare so well. So if we need to know if you have COVID so we can keep you away from high-risk individuals. High-risk patients need to be considered for closer monitoring and treatment. So at my system, we do home monitoring where someone calls or checks in with someone every single day via MyChart. How are you? How are you doing? COVID tends to wax and wane, up and down and up and down, either day to day or morning to night. And so people may be fine, and then 4 to 5 days later, they are not. And so we know symptoms to look for to warrant, this is why when you need to go to the emergency room. That's what I'm telling all my patients when I connect with them, no matter their vaccination status or not. Assessment for dyspnea is very important. This is shortness of breath. So these are some questions you can ask your family members or loved ones if they're having to figure out if they're short of breath. What activities that you could previously do without difficulty are now causing you to be out of breath? So I'm giving the example of a shower. If you used to be able to take a shower with no problem, but now you can hardly take a shower because you're so short of breath, that's a problem. Go to the emergency room. Has this gotten worse over the last 1, 2, or 3 days? Some people, usually COVID starts off kind of mild and then it can get really worse really quick. That's a reason to seek higher level of care. Are you breathing harder or faster than usual when sitting still? This is a big one. We should not be short of breath just sitting still. Can you no longer do your usual household activities due to shortness of breath? One of my ladies said, I made my bed and then I had to lay down. I was so weak and so short of breath. That's a reason to go to the emergency room. Does walking cause you to feel dizzy? This could be a sign that the oxygen level is going down with activity and would be a reason to seek a higher level of care. If people have the pulse ox, which is the thing to go on the finger to measure oxygen level, we want to make sure that it stays above 90. If you have COVID-19 and you have a moderate to severe case, you may be in the lower 90s. It's not normal, but it's not, as long as you're staying in the 90s, we're more comfortable with that. My patients that are going in the 80s, I say if you take a couple deep breaths, you go right back up, okay, but really keep an eye on it. If you're going in the 80s, you're staying in the 80s, you're going lower, it's time to go to the emergency department or call 911. So let's talk about treatment. So we have some treatment updates here. So symptomatic treatment includes Tylenol, NSAIDs. At first we thought we couldn't use NSAIDs because of viral replication, but we can. So this is going to be ibuprofen, Aleve, those types of things. For the fever and body aches, with the Omicron variant, we're seeing a lot more chills, body aches, I can't get out of bed type stuff, kind of flu-like, when we didn't really see high fevers, but we weren't seeing that as much in the past. Self-proning helps a lot. If you are someone who develops COVID pneumonia, it tends to settle in the back and the bottom. So laying on your chest or your stomach helps that to not do that, and it helps people breathe. Breathing exercises. There is a million breathing exercises you can find online to really help open up those lungs. If anyone's ever had surgery and they got one of those spirometers that they had you blow in, use that because that helps open up those alveoli. Remember, we want them to get nice and open, and if they're filled with fluid or pneumonia, they struggle to open, but you can help with that. You got to stay hydrated. Many times people don't want to eat or drink, or they can't taste and smell, and so they don't want to eat or drink, and then they end up in the hospital because they're dehydrated or weak. We're prescribing Tessalon to people that works for a cough. Some people it doesn't work at all, but some people it works great. Dextromethorphan is over the counter for cough. Inhalers and nebulizers have been effective with some people for cough or shortness of breath. And if people have sleep apnea and you're supposed to be using a CPAP, use your CPAP. One of the treatments in the hospital when people are progressing is BiPAP. Keep those airways open. Your CPAP does the same thing and helps keep the airways open. So make sure you're using your CPAP. For non-hospitalized patients, dexamethasone or other systemic glucocorticosteroids are not indicated. So our steroid packs and our prednisone and dexamethasone, we should not be using on our outpatient patients, especially early on. So we were actually worsening outcomes by doing that because the steroids are potentially increasing viral replication. Now, a couple weeks into the disease, or if someone has some other comorbid condition like asthma or COPD, that might be a whole different story. So Paxlovid is the oral antiviral that just hit the market. So we just got it here in our area. We have it at our big hospital pharmacies, and I'm hearing that within the next couple of weeks, the big retail pharmacies will have it as well. These are for high-risk patients, 12 and up. and it needs to be initiated within 5 days of symptom onset. This works very similarly to the Tamiflu and the Xofluza that we use for influenza, where it shortens the time period of illness and then also reduces risk of progressing to critical illness and reduces risk of hospitalization. Monoclonal antibody treatment is for high-risk patients, and it has to be initiated within 10 days of symptom onset. We used to have a ton of monoclonals, the Regeneron, but like I said, with the Omicron variant, our Regeneron is not working, and so now we have our new our monoclonal antibody treatment, but we have a short supply of it right now. So the systems have to triage based on the highest risk patients, are severely immunocompromised, and then are unvaccinated with older age, comorbidities, kind of going down the system here with people that are at the highest risk for progressing to critical illness and death. Monoclonal antibody treatment gives your body antibodies to fight against COVID-19. So most people that have received this feel so much better right afterwards. And then I am not going to try to say this antiviral, molnupiravir. It's an oral antiviral for 18 plus if no other FDA-approved treatments are appropriate or accessible, and this needs to be initiated within 5 days of symptom onset. So we have not been using this in my system quite yet. And then fluvoxamine. A lot of us in healthcare that have been dealing with COVID-19 patients have been watching these studies on fluvoxamine. Very interesting. It's actually an SSRI. It's probably the least popular SSRI because we really use it mostly for OCD patients. But they've been doing research studies to see if it helps with the treatment of COVID and also maybe the treatment with long haulers. And the theory is it has anti-inflammatory effects. So we can use this in people over the age of 18 when no other FDA-approved treatments are appropriate or accessible. It's not recommended within 2 weeks of other SSRIs. So if patients are already on an SSRI, we're not using this. But that's kind of an interesting medication we've been following for 2 years now. Hospitalized but not requiring oxygen. So if someone's hospitalized but they don't need oxygen, remdesivir we're using for high risk of disease progression. Remdesivir does not kill people. It does not cause kidney failure. That was shared by a chiropractor and shared hundreds of thousands of times. Remdesivir helps people a lot. Convalescent plasma we were using a lot at first. It can be considered through the emergency use authorization for the immunocompromised. We're not using that as much anymore in our system. And dexamethasone should not be used in absence of another indication like asthma or COPD for the same reason I mentioned before, is that it potentially can increase viral replication. Now, hospitalized that require oxygen is a different story, though. So we know that remdesivir or remdesivir with dexamethasone has been effective in helping to prevent worsening outcomes in these patients. And then we have the convalescent plasma as well. Hospitalized requiring high flow device, so it's going to be non-rebreather at a high level or non-invasive ventilation like a BiPAP. We're using dexamethasone and remdesivir. Some of the biologics, these two are two different biologics that we use that can be added with rapidly increasing oxygen needs or systemic inflammation. And the biologics really are attacking that immune system response in the cytokine storm. So it's suppressing that to kind of help hopefully prevent those patients to go onto the ventilator. And then if they're hospitalized and they require ventilation or ECMO, dexamethasone, and the biologics and remdesivir does not appear to be beneficial in this group, because all of those are really supposed to use a little earlier on before people are, to prevent them from having to go on a ventilator or ECMO. So I have lots and lots of references here. I have a couple more slides of references to add because I had to throw the last couple of slides together pretty